Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-rehman and I'm the founder of Medurstand-Understanding Medicine. Today I'm going to talk about this condition called hyperparathyroidism. This is the second in the series of lectures on calcium homeostasis, and if you just landed here, I strongly recommend that you should also see my earlier lecture on calcium homeostasis because some very important concepts are explained there. So if you watch this video after watching the other one on calcium homeostasis, I guess you will understand it better. We have four parathyroid glands on the average. Some people have more, some have less, but they are four. They're situated behind the thyroid gland. We can't see them, we can't palpate them, but they are there. They function as one gland functionally because they respond to the command in the same fashion. Unless one of them becomes autonomous or a tumor grows in one of them, then of course that would result in this condition called hyperparathyroidism. Four glands located behind the thyroid gland function as one. So they regulate our calcium, they regulate our phosphate and vitamin D metabolism. And since calcium is extremely important for our body function, very important functions, heart related function, brain related function, nerve related function, intestines. So everything is actually dependent on calcium, even our clotting system. So the parathormone is extremely crucial for our life. The causes of hyperparathyroidism could be of three types. The first is primary hyperparathyroidism when there is adenoma in the parathyroid gland. You know, our normal parathyroid gland, they respond to hypercalcemic stimulus. If there is enough calcium in the body, they will suppress our parathormone. But if there is adenoma, this adenoma is wild tissue and it is non-obedient tissue and it is autonomous tissue, and despite having signals from the calcium, it would continue to produce large amount of parathormone, and parathormone when in very large quantity will produce a disease, and that is called hyperparathyroidism. Truly speaking, primary hyperparathyroidism is actual hyperparathyroidism. Then there is a secondary hyperparathyroidism. This is actually a physiological response to chronic hypocalcemic state. For example, if somebody is malnourished, not having enough calcium from the diet, there is hypocalcemia, and that hypocalcemia will stimulate parathormone production. So that is a physiological adaptation. Similarly, in chronic renal disease, there is hypocalcemia that will also stimulate parathormone as an attempt to correct hypocalcemia. So it will actually correct hypocalcemia to a certain extent. So you could call it a physiological adaptation. But since this chronic hyperparathyroidism, even in this state, can cause increased bone loss, so it is considered a pathological condition in that sense. So that is also addressed. Third is tertiary hyperparathyroidism. I'm not sure how common this condition is. I haven't seen even a single case, but theoretically, this is a condition where there is chronic hypocalcemic state, a chronic compensatory hyperparathyroidism, but suddenly one of the glands, because of the chronic stimulus, becomes autonomous, and that makes a tumor, and then it becomes practically a primary hyperparathyroidism. So this is actually theoretically very rare because these days we can recognize these hypocalcemic state, we can correct them. So I hope nobody should go into this stage that he or she would develop tertiary hyperparathyroidism. Primary hyperparathyroidism will be talking about most. There are three possible causes of primary hyperparathyroidism. First is just sporadic solitary adenoma. Just any person can develop an adenoma because our growth is regulated by certain growth factors, but sometimes something goes wrong and a tissue grows into a tumor. So, and adenoma could arise from parathyroid gland, and since these cells are functioning cells, they would produce a lot of parathormone and secondary effects. Then this adenoma may be part of what is called MEN, multiple endocrine neoplasia. I actually recently saw a case who presented with hypercalcemia. We did his ultrasound and other tests. We found an adenoma. We removed it, but we continued with the investigation for men, and we found an ependymoma in the brain, because ependymoma is also one of the associations of men. Men basically consists of multiple endocrine neoplasia, but there's a long list of non-endocrine tumors which can also be associated with men. In this unfortunate guy, it was ependymoma, which caused actually hydrocephalus. Then sometimes there is idiopathic hyperplasia. Now, in my previous slide, I mentioned when there is chronic hypocalcemic state like malnutrition or renal failure, that would physiologically stimulate parathyroid gland, and parathyroid gland will be physiologically hyperplastic. But sometime in the absence of hypocalcemia, there is some unknown signal coming from somewhere. It is stimulating all four glands and it is producing idiopathic hyperplasia. So they produce too much parathormone. They just work like adenoma, but the difference is in this condition we will have to remove adenoma only, but in this condition we will probably have to remove all four glands and then re-implant a portion of one of the glands. Now, pathophysiology, this slide I discussed in much greater detail in my earlier lecture. So those of you who are interested to understand this, they refer to the previous lecture. But here very briefly, I'll mention some of the important points. What happens in hyperparathyroidism? There is excessive PTH because there is adenoma. The adenoma doesn't listen to any command, it is just producing PTH in large quantities. Or there is idiopathic hyperplasia that is also producing PTH in large quantities. Now PTH has got certain function in the body and it would stimulate osteoclasts in the bone marrow, and will mobilize calcium and bring it back to the calcium serum and the blood, and there would be hypercalcemia. It would also stimulate GI absorption through activation of vitamin D, and that will also, from the same food, it will absorb more calcium than increasing serum calcium further. And it will also reduce urinary excretion. Parathormone helps to reabsorb calcium back into the circulation. So again, that will contribute to hypercalcemia. So this is how massively elevated PTH causes hypercalcemia, which is actually the main biochemical abnormality in this condition. Now there is massive hypercalcemia, which is refractory to normal physiological corrective methods, and it would cause hypercalciuria also. Now let me explain one point. Normal function of parathormone on the kidneys is to help reabsorb calcium. So you could say if there is too much parathormone, there should be hypocalciuria. But since there is so much calcium in the extracellular compartment, despite that effect of parathormone on the tubules, there is massive amount of calcium being excreted and is brought to the nephrons. So despite increased reabsorption, there is hypercalciuria. Now this is important because there is a similar condition I'll shortly discuss, and that is differentiated from primary hyperparathyroidism by this fact that in that condition there is hypocalciuria. And all this constant stimulation of osteoclasts will lead to demineralization. Initially, there will be osteoporosis, but then later on, there may be subperiosteal erosion. There may be actually cavity formation called osteitis fibrosa cystica, and there may be pathological fracture. And because the lot of calcium is excreted or passes through the kidneys, it may deposit in the renal tissue called renal calcinosis, or it may make multiple stones, typically on both sides, nephrolithiasis. So because of this mechanism, two organs will be affected. One will be the bones, bone will become weak, and the other will be kidneys, and kidney may become non-functioning. And there will maybe stone formation. Clinical manifestations are related to hypercalcemia, and they are related to bone disease, and they are related to kidney disease. So you can just imagine hypercalcemia. I think I'm going to show you in some more detail in some subsequent slides. So at this time, just remember that the clinical manifestations of hyperparathyroidism, they relate to the calcium level itself, or bone or kidney, which are two organs which are mainly affected by hyperparathyroidism. Now, this is a statement, an acronym, and people with hyperparathyroidism, they present with stones, referring to multiple kidney stones, and bones because they have bone pains and bone fractures, and moans because they have pain in the body all the time and they moan all the time. So stones, bones, and moans, this is the classical triad of hyperparathyroidism. These days we go by more specific clinical signs and with more specific laboratory abnormalities, but this is like traditional approach to simplify the disease. What are the complications? Some of the complications are related to hypercalcemia and bradyarrhythmias. Calcium is very important to regulate our rhythm. Hypercalcemia as well as hypocalcemia. Today we are discussing hyper. Hypercalcemia can cause some bradyarrhythmias. Now, hypercalcemia tend to cause bradyarrhythmias, and hypocalcemia tends to cause tachyarrhythmias. So there may be bradyarrhythmias, even blocks. There may be mental changes. Their patient may be confused, disoriented, or may actually have frank mental disease. Or there could be secondary hypertension. One of the causes of secondary hypertension is hypercalcemia. Or hypercalcemia is also one of the causes of pancreatitis. And it may also cause refractory peptic ulcer disease. So of course these are non-specific. There are other causes of these conditions, but in the context of hyperparathyroidism, you should consider these as complications of hypercalcemia. Then we have some clinical manifestations, some complications due to bone demineralization. Patient would complain of bone pain, almost the whole body hurts. Patient moans all the time, but patient is prone to have minimal trauma fracture. With major trauma, like a road traffic accident, anybody can break his bones. But if somebody just have a little fall, and just changing the posture and just little bit of trauma, if that causes fracture, that is called pathological fracture or minimal trauma fracture. There are other causes of minimal trauma fractures like osteoporosis, but you must remember hyperparathyroidism as one of the possibilities because this one is treatable. Then we have kidney disease, kidney related complications because massive amount of calcium is brought to the kidneys, and that kidney can deposit in the renal parenchyma, and that can lead to a condition called nephrocalcinosis. The kidneys can be actually seen on X-ray because of the calcium, and there could be multiple stones typically on both sides. So both nephrolithiasis and nephrocalcinosis would affect kidney function. If not corrected, this would lead to renal failure. So these are the complications. I think quite a few of them are very, very important. Diagnosis is easy if you take the case methodically. Now, there are some biochemical abnormalities. Most important is hypercalcemia. In fact, many times hypercalcemia is an incidental finding. Patient may not be suspected to have hyperparathyroidism. During routine laboratory testing, one finds hypercalcemia. Then, as I always say, if there is hypercalcemia, before jumping to the diagnosis of some rare condition, reconfirm that this is actually hypercalcemia. Once it is confirmed, then you also do calcium and phosphate and alkaline phosphatase and albumin, and only then you will know that it is truly a hypercalcemic state. So hypercalcemia may be actually the main manifestation of hyperparathyroidism. It is possible that you were suspecting hyperparathyroidism, and you ordered calcium and it turned out to be high. And it is also possible that calcium was done just as the routine. Many people, they just want to have the routine test and hypercalcemia was detected. In either case, it is an important manifestation of hyperparathyroidism. Hypophosphatemia, because this parathormone has opposite effect on calcium and phosphate. It tries to preserve calcium, and that is why it results in hypercalcemia, but parathormone tries to excrete phosphate, so there would be hypophosphatemia. Then because of there is bone loss, calcium is being mobilized from the bone, and bone cells, the osteoblast, will respond appropriately by making more bone. And once osteoblasts are active, their manifestation is increased alkaline phosphatase. Again, there are many other causes of elevated alkaline phosphatase, but if you have a triad of hypercalcemia, hypophosphatemia, and elevated alkaline phosphatase in a person who was complaining of body pain, the diagnosis of hyperparathyroidism is extremely likely. Then we measure PTH. The parathormone test is available and it is to be done in every patient with hypercalcemia, and we measure intact PTH. Now, why I say intact? Because previous assays used to measure only one part of the PTH, and we could get falsely elevated or falsely reduced level. So once we measured intact parathormone, then we are sure what we are measuring is actual parathormone. So parathormone assay will show that hormone level is increased. Then parathyroid imaging, very, very important, because we have diagnosed hyperparathyroidism, but we have to find the actual culprit, what is causing hyperparathyroidism. It is likely to be a tumor, and mostly in the parathyroid gland itself. Occasionally, the parathyroid gland may be situated elsewhere, so the tumor will also be elsewhere. So I think in majority, if we do ultrasound of the neck with a specific request to the radiologist that we are suspecting a parathyroid tumor, he will see these tissues through the thyroid gland and will be able to tell you if one gland is bigger, much bigger, significantly bigger than others, then that would suggest a tumor. Because if you have a tumor in one parathyroid gland, others are likely to be suppressed, because this parathormone would be suppressing, it would be causing hypercalcemia, and hypercalcemia will be trying to suppress parathyroid tissue. It will only be able to suppress the normal parathyroid, not the adenoma. So you will see the disparity between one tumor and other tumors. In some cases, there could be hyperplasia of all four glands. I guess it may not be possible, or it may not be easy at least to say for sure that there is hyperplasia of four glands on ultrasound. So then there is a test called sestamibi scan. This is actually a scintigraphy test, and this is relatively traditional, and this would detect functioning parathyroid tissue. Within the parathyroid locality or if it is somewhere else. Usually it is done after the ultrasound. I think if ultrasound shows a tumor, next step may be to do a CT scan or MRI, because that gives you the greater details of the tumor. But if you have a state of hyperparathyroidism and there is no growth in the parathyroid glands, then we do cystectomy to find an ectopic gland which might have grown a tumor. It may also be helpful to find metastasis if this tumor is malignant. Then skeletal survey, because a chronic hyperparathyroid state will demineralize all bones. There may be some silent fractures, there may be some cavities formed. So we do X-ray of the whole body, and specifically those regions where we expect the abnormalities, like we do X-ray of skull, we do X-ray of jaw, we do X-ray of long bones. So that is called skeletal survey. Then finally, there's a test called dual energy X-ray absorptiometry. This is a very famous test abbreviated as DEXA. The commonest application of this test is early detection of osteoporosis. But it is also helpful here because what it is going to do is it is going to measure the bone density. So in hyperparathyroidism, because of chronic demineralization, bone density is likely to be reduced. So these are the tests. I think if you go methodically, I believe in majority there should be no difficulty in establishing the diagnosis of hyperparathyroidism. These are some of the examples, the bone survey. Now you can see this is a very decent joint, but you can see this punched out lesion. This is actually a cavity. Now, how do I know this is hyperparathyroidism? I can't tell actually, unless I know the background. So if the patient has the proper context, then these cavities could be interpreted as manifestation of hyperparathyroidism. Uh, these cavities. So there are other causes of these cavities. For example, metastasis could also present as cavities, but in proper context, these cavities would indicate a, what is called osteitis fibrosa cystic. Luckily, these days, early diagnosis is possible, and I think no patient should go to this extent that he would develop these cavities. This is another cavity and punched out lesion. This is in the skull, and you know the lateral X-ray of the skull we also do in multiple myeloma. Very similar, but typical numerous punched out lesions are seen in multiple myeloma also. So you can make a proper diagnosis only in the proper perspective. And in this X-ray, you can see these bones. These phalanxes are, there is subperiosteal erosion. So you can see that these bones are eroded and narrowed down. There's something called lamina dura. This is X-ray of teeth, and normally there is a casing of bone here, and this is the place where my cursor is. There is supposed to be a very thin bone here because it is normally paper thin. So whenever there is a resorption of bone, this may just disappear. So this has become famous as loss of lamina dura. This is, my picture is blocking it, but this is written loss of lamina dura. So normally there is supposed to be a thin bone folding like this that is absent. So that is also a feature of chronic hyperparathyroidism. Now, we normally do not do bone biopsies, but if for whatever reason you get a bone sample, you can see the difference between normal bone and the hyperparathyroidism. This is much of compact bone and the cavities contain bone marrow. But this is, the cavities are much more, and this has become like a sponge-like structure. Of course, this bone will be much more prone to fracture as compared to this. That is why these patients develop minimum trauma fractures. Treatment of hyperparathyroidism, of course, we need to address the primary cause, but hypercalcemia is the main manifestation. I discussed the management of hypercalcemia in greater detail in my earlier lecture, but very briefly I would mention here, before you undertake surgery in these patients, first you have to fix this hypercalcemia. Hydration with normal saline and furosemide. So normal saline will dilute our extracellular compartment and bring down calcium to a relatively safer level, and with diuretic we will excrete calcium from the body. So both when together they will help you bring the calcium down. Of course, furosemide is also needed because we are giving very large amount of fluid. So to prevent any volume overload, we are giving furosemide also. Bisphosphonates, because they inhibit osteoclast, they encourage deposition of calcium in the bone, so they will also reduce serum calcium. Typically, bisphosphonate would be given in the form of injection in this situation, like zoledronic acid. Then calcitonin is a hormone which again helps for calcium to go to the bone and get excreted from the kidney. So calcitonin injection can be used in hypercalcemic state. Mithramycin is an anti-cancer drug, but is also helpful, especially if the hypercalcemia is due to malignancy. But I believe even in other types of hypercalcemia, mithramycin has some role. IV steroids can be useful. IV phosphate, because phosphate they bind with calcium to make insoluble salt, and that can immediately lower calcium so fast that patient may end up in hypocalcemia. Now, hypocalcemia is as big a problem, if not bigger, than hypercalcemia. So one has to be very, very careful when giving IV phosphate. So I think this kind of job should be left to the specialized center. IV fluid and furosemide is very simple, very safe. If you do not have the proper facilities, I think you should just be happy with this one. Dialysis, if somebody has kidneys are affected, kidneys have shut down, then dialysis would be considered as a last resort. So this is just the management of hypercalcemia. We will still have to deal with the hyperparathyroidism, the tumor itself. And best is of course the surgery. And first we have to localize. We localize by ultrasound, by CT, by MRI, by sestamibi scan. And after localization, we remove. But one word of caution, if you remove the tumor, there is a risk of hypocalcemia. Patient was in a chronic hypercalcemic state, and suddenly you have taken out the tumor, and tumor had actually suppressed the remaining parathyroid tissues. So because the parathyroid tissues are suppressed and adenoma has been taken out, there could be immediate hypocalcemia, and bones are also demineralized. Once that stimulatory effect on the osteoclast is lost, bone will start reabsorbing calcium from the taking up calcium from the serum. This is called hungry bone syndrome. So be aware of hypocalcemia when you remove tumor. I always say that all endocrine surgeries should be done with the help of a physician who understands this stuff. So immediately after surgery, there is a risk of hypocalcemia. One need to be prepared. Of course, we have to give calcium infusion and maybe if needed some other stuff also, but hypocalcemia has to be prevented because it is bigger evil than hypercalcemia. Then secondary and tertiary hyperparathyroidism, I think very briefly, I'm going to discuss these two conditions. Secondary hyperparathyroidism is actually a physiological response to hypocalcemic states when there is chronic renal failure or vitamin D deficiency. Parathormone will respond appropriately to hypocalcemic state as an attempt to keep calcium normal. So in this way, it would be a physiological state, but if you measure parathormone, it would be high. In the context of chronic renal disease, it is actually a physiological adaptation, but uh, this chronic hyperparathyroidism will further weaken the bone, so that is considered a pathological state. We try to correct calcium and we try to bring down phosphate by other measures so that stimulus for hyperparathyroidism is reduced and hyperparathyroidism is corrected. The treatment is focused on the primary disease. Tertiary hyperparathyroidism is a very rare condition. Now, it is a condition when patient had long-standing hypocalcemic state and there was stimulation to parathyroid gland, and this is secondary hyperparathyroidism. But because of the chronic stimulation of the parathyroid gland, one of the glands, it developed tumor. So once tumor is there, then it will just act like primary hyperparathyroidism. So in my belief, this is very rare condition, and these days nobody should actually go to that extent. And the treatment, of course, we need to treat the underlying cause, which was responsible for chronic stimulus for parathyroid gland. But since the tumor has already developed, we need to take it out also. Now I would discuss the differential diagnosis of hyperparathyroidism, various types, and a condition called familial hypercalcemia. And this comes in the differential diagnosis because of hypercalcemia. You know, the main biochemical abnormality in hyperparathyroidism is also hypercalcemia. So that is why I would like to discuss this condition briefly. In primary hyperparathyroidism, PTH is understandably high because there is a tumor and the tumor is producing abnormal amount of PTH. Now, PTH would obviously cause hypercalcemia. Now, so this is also easy to understand, and this large amount of calcium is excreted into the urine, resulting in hypercalciuria. In tertiary hyperparathyroidism, the biochemistry is exactly the same as we expect in primary hyperparathyroidism, because once a tumor develops in parathyroid gland, practically it becomes primary hyperparathyroidism. So you will not be able to differentiate between the two conditions from the biochemistry. You need to know the history. You need to know that this patient had some chronic hypocalcemic state which resulted in this tumor formation. So that is how we differentiate. And secondary hyperparathyroidism is actually a condition which develops in response to chronic hypocalcemic state. There may be chronic renal disease or malabsorption or malnutrition that results in hypocalcemia. Hypocalcemia will stimulate parathyroid gland to make more parathyroid hormone. So that is why when you measure parathormone, it will be high, but it is physiologically high. And urinary calcium is low because there is not much calcium in the extracellular compartment to be excreted. And whatever calcium we have, parathormone is trying to preserve it and is bringing back to the circulation, so there will be reduced urinary calcium. Now this condition, familial hypocalciuric hypercalcemia, they actually have some problem with their kidneys, some enzymatic defect which is causing which is not allowing the calcium to pass to the urine, and that is brought back to the extracellular compartment. So that will cause hypercalcemia. Hypercalcemia will physiologically suppress PTH, so PTH will be low in this condition. So, and since main biochemical manifestation of hyperparathyroidism is hypercalcemia, so I just give you the list which I discussed in my earlier lecture: hyperparathyroidism, malignancy, and vitamin D intoxication. In majority, if you see a patient with hypercalcemia, in majority you are dealing with hyperparathyroidism. In some you are dealing with, in 15% you are dealing with a malignancy, and in less than 10% you are dealing with vitamin D intoxication. In my next slide I will show you how to differentiate between these three conditions. These are actually diagnosed on the basis of other tests. I think discussion about these is beyond the scope of this lecture. Now, this slide shows the differential diagnosis between three common conditions of hypercalcemia: hyperparathyroidism, malignancy, and vitamin D intoxication. And in hyperparathyroidism, of course, PTH would be elevated and calcium is also elevated. We have already discussed in detail. And this PTH related peptide will not be there because it is not produced by the parathyroid gland. It is actually produced by the malignant tissue. In malignancy, the actual abnormality is this one: production of parathormone related peptide. It is something which works like parathormone but is not parathormone itself. So when you measure parathormone, it would be actually low because this would cause hypercalcemic state, and hypercalcemia would suppress normal parathyroid gland and PTH level will be physiologically low. And in vitamin D intoxication, because of excessive function of vitamin D, primarily there is hypercalcemia, and once there is hypercalcemia, that would suppress parathormone and PTH level will be low. So this is how we differentiate between three common conditions causing hypercalcemia. Thank you very much. This brings us to our last slide, and this is the end of my second lecture on the series of calcium related disorders. And this was hyperparathyroidism, and I really look forward to see you in next two lectures, which are on hypoparathyroidism and vitamin D deficiency state. Thank you very much for watching.